I'm your host, Christopher Habig, and this is Healthcare Americana. I'm now joined by Dr. Beth Haynes, an emergency medicine physician for 20 years, who has spent the past 10 years in health research policy and education. Dr. Haynes, thanks for taking the time to come on the show and share your experiences with everyone.
Sure. Glad to be part of this conversation.
Now, throughout your involvement in various organizations, there's a litany of boards that you sit on to help in the health policy area. What have you seen from those organizations as you've been involved, and specifically, how has the direct care movement been involved within those organizations?
Oh gosh, the first organization I got involved with was Doctor for Patient Care, right after the passage of the Affordable Care Act, and we spent a lot of time going, talking to representatives, senators in DC, and nobody had ever heard of the idea of membership medicine, which, the language was very new at the time, but it was being called direct primary care, and everybody kept thinking, oh, you just mean concierge for the really rich people, right? And trying to explain that. And Lee Gross was just amazing at the ability to meet with Democrats and Republicans. It didn't matter. People saw immediately that this was a great way to offer affordable quality health care for people. And there was a lot of enthusiasm, but a lot, people just didn't know what it was. And then with that, it's gradually grown. Doctor Patient Care started off as a C6 membership organization. It's now a C3 educational organization as a foundation. And it's continued to stay very, very involved with educating people about direct primary care. In fact, we just had the annual conference, Nuts and Bolts Conference, down in Orlando. That's one of the key things that Doctor Patient Care Foundation has been involved with. So probably it's the largest that it is currently involved with, although they've been really concerned about certificate of need and just the debacle of the top-down electronic medical records and its interference with the doctor-patient relationship, and also maintenance of certification. Mm-hmm. There was one other thing that they're involved with. It'll come to me later. Anyway, they took on a few things that's been involved with that. For many years, I was running the Benjamin Rush Institute, which worked with medical students, and trying to bring non-government solutions, private solutions to the challenges that we face with healthcare to the medical students and get them thinking outside the box, because most of the health policy instruction that they receive, which is very small to begin with, really is heavily tilted towards the government has to solve this problem. And direct primary care was definitely part of that and was the most enthusiastically received. Again, across political divide. It's just people can respond to this as this is a great way for people to benefit, period.
Mm-hmm. So a lot of work in more of a free market sense, which again fits very well with the message of Freedom Healthworks and with direct primary care in general is, hey, why don't you leave it up to the people on the ground to actually fix a lot of the issues that plague our system here in our industries, and not looking towards Washington for some type of magical one-size-fits-all legislative effort. And a lot of the efforts that you've been involved with are just breaking down the barriers that physicians like yourself see that get in the way of caring for patients. I mean, is that fair to say?
Oh, absolutely. And, if you put something that's top down, like that was done with the electronic medical records, you really crush the innovation and the ability of physicians to adapt that system in a way that makes sense clinically, that serves what's going on at the point of care. Right. And it's pretty obvious to people now that the way, well-intended in some respects, they wanted to bring doctors into the 21st century and digital access and the efficiencies that has provided to every other industry. But at the same time, they wanted to improve data collection and have, for Medicare, it was also important to be able to get the right billing and facilitate that for the private insurance. And it became a huge data collection source and billing mechanism at the expense of really improving clinical efficiency. And because it was built into the law, it takes an act of Congress to change it, right? So there was, even though we were starting to see physicians create their own electronic medical records, all of that was crushed. All of that innovation was just thrown out the window because it was, you could have this big carrot of extra pay from the government if you adopted, and then there was penalties if you didn't adopt their specific design for the electronic medical records. So if you take that experience and then you put that same approach into innovation in healthcare delivery, you're going to find that same crushing effect on all these innovations and things that are just starting beginning to get started and really take off, like direct primary care or cash payment for outpatient surgeries, even cash fee for service in the specialties, because physicians, that our time, we're highly educated, but the actual service that we're offering could potentially be much lower, except when you add all these middlemen, like all the billing and the insurance, that kind of stuff actually artificially inflates the cost to the patient.
Right,
So
right.
we want that innovation, and that's what the concern is. That's why we want to leave. I think that there's that powerful argument. Let's not have a top-down implementation or design of things.
Yeah, and you look at it from a supply and demand aspect too, where, I don't care what people say, but the prices that you charge or able to charge in downtown Manhattan in a physician practice in Times Square is going to be a lot different than what you charge in a farm community in the middle of Kansas. It's just a fact of life. It's just economics 101. So again, that top-down approach just doesn't fit within the healthcare industry really at all. And
Well,
so
the
to see,
pricing doesn't fit anywhere, right?
right,
Price setting,
right.
but it's also the design. I mean, the government didn't price set and say you can, this is what the EMR has to cost, but they put so many requirements in it that inflate the cost, and design elements that it's not even serving things. So
Right.
I don't want to see that in delivery of healthcare.
Right, exactly. But a lot of those, the meaningful use in those quote unquote, with kind of air quotes, the incentives to be able to code, it just, that drives actions. Everybody knows
Yep.
that. Anybody who's studied behavioral health, I mean, incentives drive a lot of what people's actions are, especially their motivation. So going back to breaking down the barriers and this whole theme that you've been talking about so far of not impacting the delivery of healthcare, you mentioned your work with the Benjamin Rush Institute and working with medical students, and you said this has a wide appeal, this type of direct care model, whether it be membership or whether it just be cash transparent prices, has a wide appeal. Why is that, in your opinion? Why does this type of a model appeal to so many doctors, from medical school all the way up to physicians who might be nearing retirement age?
Oh gosh, it's sort of, it's, I think there's nostalgia for the days of the family doc that has time to really get to know their patients. There's continuity of care throughout the family, even with internists or pediatricians, to take care of all the kids in the family, not just spotty. There's nostalgia amongst the doctors that are older, wanting that model to return and not seeing patients jerked away from their practice because the employer-sponsored health insurance plan has changed. Or for whatever reason, right? So I think people want the time with their patients. That's a huge part of why people go into medicine in the first place, is wanting to interact with people. To me, medicine is like the absolute pinnacle best of science and working with people. It just brings that all together, and it's been lost. That art that well, it's been challenged. I don't know that it's been lost. That's too dramatic, but it certainly has been eroded into the doctor-patient relationship with just now you hear that for every minute a doctor spends with the patients, there's 3 to, I've heard as high as 7 minutes worth of just desktop medicine, which is the new term for paperwork. And
I
this
like
is
that,
all,
desktop medicine. Wow, that's a new one. I don't
yeah,
think I've heard that one yet, but
the whole push is to not be paper, but electronic based. So you can't talk
right.
about paperwork anymore. But so they see that the relationship is really preserved. The pace of the practice of medicine, the control over your hours, it still allows physicians to get a very reasonable amount of earnings.
Mm-hmm.
And it just, I think that's what excites them. It's also, your own boss is very exciting. And I think that there's been a big push towards people just assuming they're going to go work for a large physician multi-specialty organization or be paid, an employee of the hospital, and here's an alternative. So there's still some remnants of that that's available. We actually assisted in a research project that was put together by a PA student, that they did a survey before and after hearing about direct primary care, about the interest of medical students in being a primary care physician. And it significantly impacted students' interest in primary care. And I think seeing physicians who are happy, love what they're doing, I think all of that plays into the response that we see with medical students about this model.
Yeah, that's great. And I'd be interested to take a look at those survey results, because that's something that's real and actionable. You can show that to people and say, hey, look, people want to go into primary care, but they might be hearing in medical schools that, hey, you're too smart to be a primary care doctor. Why aren't you going to go be a specialist? So there's a big stigma out there about being a primary care physician. It's just like,
Absolutely. And it's old. I was told that you want to be because even though I ended up doing emergency medicine, there were no emergency medicine residencies at the time. And I really wanted to be a family doc. And people, all my preceptors were saying, oh, you're much too smart to do that. You should do something else. And to find out that even in this day where there's all this lip service given to how much we need primary care, that in these academic centers, this is still the message that's being sent to the students. It's just, it's telling. It's very telling.
yeah, it is a shame. And you mentioned a couple of things and themes that I love when they come out, that medicine is really an art form. You said it was at the intersection of science and humanity. And to me, that is pretty much defined. That's a great definition for a form of art. And then you mentioned how, we say that medicine's not really a career, it's more of a calling. And when you're able to put a delivery model in front of somebody and it changes their opinion about it, specifically within your survey or within direct care, enticing more people to go into primary care, this seems like really like a no-brainer. And you kind of scratch your head and say, okay, if there's 1,100 direct care DPC practices in the US right now, it's growing like crazy, but there's still not enough practices out there to really make as big of an impact in the industry as we'd like it to. What are some of the issues you see to this model being more widely adopted?
Oh, I think the Affordable Care Act is a huge disincentive for patients to be involved with this until they understand. Because so we're reaching some physicians and they're fed up enough with the sort of treadmill practice of medicine that is sort of dominating things. I mean, that's, I think, a big
Yeah, it's the reality of
source
it.
of all the burnout and just frustration that you hear the physicians talk about. But so patients aren't aware of it. And if they're, because the Affordable Care Act said in your insurance, or what they're, so it's not even insurance, right? It's a coverage plan.
Mhm.
And it has to do too many tasks that really insurance was never intended, is not mathematically capable of doing both high risk catastrophic care and these predictable, low cost, point of service primary care type of things. It just mathematically, if you understand insurance and risk management, it's not a risk. Primary care is not a risk. So the Affordable Care Act required that these plans, these health plans, cover something. So people, in order to be involved with a direct primary care, end up paying twice. And there's laws that prevent people from using their health savings account in order to pay for the membership fee of direct primary care. So again, there's a tax disincentive for people to be able to really not have to pay more. It doesn't make, there's economic incentives are tougher. So I think that's a big barrier, and I think just it's still new enough. Physicians coming out of school are coming out of school with a big debt. They don't know how, there's no instruction in medical school how to manage all of that debt, maybe minimize it. I'm not sure all of what goes into it. Some of it's the tuition, but some of it, I'm not sure. There may be some more to it than just the tuition, what causes it. I mean, I came out of medical school $20,000 in debt. That was the sum total of my tuition. Now, my same school, instead of being $5,000 a year, is now $30,000 a year. But that still is way lower than the $500,000 or $250,000 debt that people are coming out of school with. So there's some education that needs to be done of how to manage money while they're in school so that they don't come into so much debt, and then how to manage their funds after they get out of school. So yes, you actually can start up your own business at the same time you're paying back your loans. This is really feasible if you do it intelligently with the education. You don't have to just go and sign a 10-year contract or some long-term contract as with an act as an employee. So I think those are some of the barriers, both the patient awareness and the negative tax incentives for them, and then the student awareness about just the financial realities of being your own boss and starting your own business.
Right. It doesn't seem like a lot of the medical schools or residency programs are really pushing independent medicine or independent practice anymore. And it's kind of like, well, once you're a physician, once your residency is over, you get a bunch of job offers from a bunch of different hospital systems, and nobody that you ever talk to even thinks about going independent anymore.
Well, part of that is because in order to go independent, you have to actually be pro-business. And amazingly, academic medicine is not pro-business. And they actually, the overall message is that medicine is more like being a civil servant than being an independent professional.
Interesting.
Yeah, and part of it is just this antipathy towards the idea of profit. Seeing it as an evil something. Profit is evil, rather than just it's what it costs you to offer the service minus the value that it is to the people that you offer it to. It's a math equation, and profit can be a positive incentive for those people who are working towards efficiency, and for the people who are corrupt and don't have a good moral compass, then yeah, it can be a bad incentive, but it in and of itself is neutral.
So on that vein, and taking that, because it sounds like there's a shift of mindset, and I'm going to attach that to kind of a political motivation here. And you mentioned the ACA before, but is something like direct care or direct primary care, is this a care model that can rise above the political fray?
Oh, absolutely. absolutely. And the more that employers understand um, self-funding, and some of the stuff that's coming out of what Dave Chase is doing through in the Health Rosetta, and the ability to instruct smaller and smaller uh, employers, or when I say smaller employers, so employers with fewer employees, about the financial advantage of self-funding. And then really that they are liberated, even under the ACA, to be able to create a true catastrophic health insurance program and pair that with stop loss, and you've got something that's affordable to cover the big items for these employers, and pair that with a direct primary care model, which is really affordable for people.
Hmm.
um, what's not to like, you know? What's
Yeah,
not to like?
it doesn't matter which way you vote if you're able to get better care from a physician. If that physician's able to price locally, they can charge according to their community and become a staple in their community again. It's hard to see, you know, I mean, this model works for urban areas, it works for rural areas, it works for suburban areas. I mean, I have a hard time understanding which side of the aisle this type of delivery model would anger.
Well, yeah, I think it's I s- it's an interesting question. There's an issue that's very big for the people who lean towards government solutions, to make everything equal. And so that if there's inequality in the system, that rubs them the wrong way. So that if and the problem is, if you try to legislate equality, there's just it just seeps through the seams. I mean, you can look at Canada, you can look at the UK. There, even these heavily government um, operated healthcare systems, there's tremendous inequality.
Hmm.
You're just not going to get rid of that inequality. So I think it's a false goal, but I think that's something that drives them. And I understand that, wanting not wanting people to fall through the cracks, right? And I think even within the direct primary care model, there's a way that we can adapt that to cover the people who aren't employed, who are in employers with employers that are small enough that can't afford to give them, so you could do something where the state is providing the catastrophic care, and setting up is a little bit along the lines of the Healthy Indiana plan. But you would give people a state taxpayer funded equivalent of a healthcare savings account. And then those people in that system are not second class citizens. They don't
Right.
go there with a Medicaid card that pays pennies on the dollar to the physician. It's like people don't turn away, grocery stores don't turn away food stamps, because that food stamp is the same as a dollar. People can decide how they're going to spend their food stamps within limits. They can't spend it on alcohol, but you could do the same kind of thing. Give these people with lower incomes or no incomes the power over their own purchasing decisions, and
Hmm.
make it equivalent. Then you're just elevating the experience that they have. And I think the DPC model would be perfect for something like that.
Especially in regards to equality. I mean, I don't know what is more equal than if a physician wants to start up for a very low membership fee. No matter who walks through that door, the membership fee could be $25 a month. And that's the equality and access right there. And sure, if somebody is absolutely destitute and they say, look, I don't have two pennies to rub together, um, you can offer scholarships. You're outside of the bounds of these contracts that bind you, or you've opted out of Medicare. So no one's going to come at you for charging less than what Medicare is able to reimburse. So to me, within healthcare, a direct care relationship with your physician is the most equal type of relationship that you can have for somebody providing expert healthcare services. Am I reading that right?
Yeah, I think so. And for physicians now that are not working at a federally qualified facility, for many of them, accepting Medicaid patients is at a financial loss to them.
Right.
So, that what kind of incentive is that? And if there was and there is a way to set it up so that financially it's the same, their experience with that patient, whether um, the patient is having a self-funded HSA equivalent and coming in there and paying the membership fee. It's the same financial experience for the physician, and it's a vastly improved experience for the Medicaid patient. I think it really rips down the barriers that physicians have to accepting Medicaid patients,
Mm-hmm.
many of whom are sicker and require a lot more time. They have fewer social supports, and so they're actually more work for many physicians. But a DPC model would allow physicians to be able to have that guaranteed income and still be able to put the time into assisting those people. So anyway, I think should work. And if, to the extent that we could have people who are looking for a government solution to look at this proof of concept, there's some really cool DPC practices that are set up as nonprofits, and they charge their paying members a bit more than what actually would need to be, but that excess contribution ends up going to pay for people like undocumented immigrants, which the ACA doesn't cover at all anyway. So
Right.
it's those kind of creative solutions, and all medical care is local anyway. I think this whole thing about being able to buy insurance across state lines, it's tough because medical care is local.
Mm-hmm. Mm-hmm.
And that's only a small part of the problem. And the more the community is working to solve those problems locally, I think we're going to find more creative solutions that work for everybody. It's got to work for everybody to be sustainable and go forward.
So we've established that DPC is something that is a bipartisan delivery model. It's something that appeals to doctors of all backgrounds, all ages. It is something that all types of patients can benefit from. So again, kind of go back to that question I asked earlier: is what is holding this back? And recently, it seems to me, and I know you have opinions on this, that even within the small, relatively tight knit direct care community, there seems to be some kind of splintering factions and some lines that some certain organizations are drawing in the sand and bickering over very small differences. To me, that is something that we have to keep our eye on, because that could be very crippling to a small movement like this, because like we've been talking about for the past 20 minutes, like this is something that has mass broad appeal. The education's not there yet, but why is it that some people within this direct care movement are kind of going back to their corner and saying, we're going to go do it this way because your way of doing it over there, we just don't agree with that. So we're not going to get behind you and support you. Why is that happening?
Well, because they're people. But I look back at Docs for Patient Care and how we started and the growing pains that we went through. And it was so fabulous at the Orlando meeting to look up and see on stage throughout the day people who were involved with Docs for Patient Care at the very beginning, and then because of some of those same disagreements about how do we best go about solving the problems that we agree exist, lost track of each other for a while and had to, it was like they had to go their own path. And people talk about working with doctors is like herding cats. I mean, it's our strength and our weakness that we have strong opinions. We're willing to accept responsibility for making decisions, and we don't want to be told what to do. That's really in the culture of at least my generation and several generations following. And so I think the DPC movement is seeing some of those same growth pains where they have a shared vision of what they want to create and some very different ideas about how to get there. And as long as that is done with respect for what other people are doing, I think that's absolutely fine. It was actually Jane Orient of the Association of American Physicians and Surgeons who once said to me something about, yeah, we need all sorts of small efforts in many different places because that's what it's all about. That's how we come up with better solutions. And she never was threatened by the Benjamin Rush Institute or Doctor for Patient Care, even though we have similar, a lot of shared goals. She thought it was great. We need many lights in the wilderness. And I think that's some of what's going on. And I just invite everybody to do it with respect for each other, and realizing that there are many different paths to build this movement, and we're not all going to agree on strategy all the time. That's okay. It's the whole idea of the anti-fragility, where you have many different contributions and things going on, so that when one falls apart, there's all the other ones that can pick up and continue to move the ball forward. And at this point, it's really hard to know which is the right way. It's part of the discovery process that markets involve, where some businesses fail because they didn't quite get it right. And we need lots of businesses, so we're not all depending on one monolith, either whether it's the government or whether it's any one DPC organization.
Right, and I totally agree with that. And at times, and I mentioned this to you before, at times it feels like the direct care movement, and I use the word, is rudderless. Like it's where everybody's out there looking, searching on their own. A lot of people are making the same mistakes, and then you responded, "Well, Chris, I'm not sure that's a bad thing." And so that made me think, you know what? This might be a good thing. Like you said, it's not a fragile movement. It feels like there is actual grassroots support. There's sticking power. And if one idea or one model fails, people are working closer together now more than ever. They might disagree on personal politics or different types of, I should do this versus you should do this. But it seems like people are communicating better across this industry, even though there are more DPC practices than ever before. One last question I wanted to ask you is, and this isn't something that I want to kind of stereotype or anything with, but businesses in general have done their part, more of the nonprofit type of hospital systems, to get this healthcare industry to the point where it is right now, and what we kind of see as a breaking point type of a thing. But there seems to be a lot of distrust within DPC physicians and DPC practices that, oh, these businesses are just here to help put me back into the hospital system. At what point do DPC physicians need to realize that there are good and bad players out there in the business world, and that without them, as either the patient side or on the partnership support side, at what point do practices need to work a little bit more closely together and trust the right type of players in order for their practices and for the movement to grow?
Oh, that's an interesting question. I mean, um, I
Or do they need businesses? Can this be a
but when you say
100%
businesses,
physician?
I'm not sure what you mean. When I think about things like hospitals and insurance companies, and they again, it's not a simple thing. They're having to function. Pharmaceutical companies, all these are having to function inside some pretty tight constraints. and government imposed incentives, whether it's the insurance companies and the minimum loss ratio, which is basically saying you're only allowed 15% profit. That's it. And which is really atypical in the insurance world.
Mhm.
So the you know it's and there's some really bad people out there. So it's understanding what are the constraints that these businesses are under, and then having an open mind out there to judge the players on their own character, whether it's a different DPC organization, whether it's a business, and really be able to look at the broader environment within which everybody's operating. And some people do it with integrity and some people don't. And just because you're in a specific business doesn't mean that you aren't doing it with integrity, but you have incredible constraints placed on you.
Mhm. So it may basically do your homework if you're a physician looking to partner with a type of organization, make sure they have the right type of values, which I think that's just good advice in general when you're starting your own type of independent business or independent practice in general is get people that you think you can trust and that are going to have your best interests in mind and move forward together from
Yeah,
that.
yeah, I think so. And well, I mean, and it's a mutual best interest, right?
Mhm.
It's like, let's not, I don't think business is or needs to be altruistic in saying I'm only thinking about the other person. It's to be really transparent about why this interaction is mutually beneficial. And that's part of what I think people who are anti-business in general really forget, that people with integrity who come together for a business thing, it only works if it's mutually beneficial. And then if it's not mutually beneficial, don't make it personal.
Right.
Step away from it and say, this isn't working for me. That doesn't mean you're evil and bad and horrible, whatever. It's just, this is not a mutually beneficial relationship.
Right, right. Well, we've covered the fact that DPC it's attractive to a wider range of people. We've talked about how DPC and businesses within this industry can align their incentives, align their support offerings together to move it forward. So, looking at your crystal ball, how do you see this nationwide movement of basically free market healthcare options? How do you see this moving forward from here?
Oh gosh, I mean, I can't predict the politics of it. I think it's such a fabulous proof of concept that we I want to see more people understand what it is and what it isn't, right? So there's um, DPC can really manage a certain population, and the DPC people, I think, need to be careful not to badmouth fee for service,
Mhm.
cash fee for service, or anything, because there's a fabulous place for fee for service, and everything else in the whole market system is fee for service, and it's great. It's fee for service at the grocery store and with a lawyer and all sorts of things, so professionals, whatever. And I can't even remember the question anymore, but I think, oh, I know. I'm just really hopeful, and the more people can understand this as one piece of the puzzle, and it's a proof of concept that giving people, both the providers of care, the clinicians, and the patients, the choice to decide what works best for them, is the way that we're going to continue to come up with creative solutions to what's a really huge, complicated problem you know, of expensive care that is not meeting the full spectrum of needs for patients, which includes, not wiping out their bank account and also giving them the emotional support and connection that both doctors and patients need.
Absolutely. Well, Dr. Haynes, thanks for joining us today, telling stories like this and getting your feedback and getting your take on what really drives direct care forward and what it's going to take to continue unifying doctors, patients, and employers to get behind this effort. I mean, it's just so important. So, thank you for being a pioneer and a trailblazer for others to follow, and thanks for being an incredible example.